Good morning, everyone. Welcome to Perth Surgical and Bariatrics. My name is Dr. Ravi Rao. The purpose of this presentation is to empower you guys with all the knowledge that you need about obesity, so that once we've gone through this presentation, hopefully you will have all the information that you require as to why we are obese, how surgery works, why it doesn't work, and all that kind of stuff. Yeah? So don't hesitate to ask any questions. You can stop me at any point of time. No question is silly, all right? Okay, so obviously, multiple choice question. Obesity is a character disorder, a sin of gluttony and sloth, or is it a normal physiological response by genetically disposed individuals to our obesogenic environment? So who thinks what?
I think C.
C? 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 So we've got a very intelligent crowd today, so it's the right answer, because somebody always says B. Now, you need to have a gene that predisposes you to obesity, and when that's triggered by an environmental factor, that's when you become obese, okay? So, now, we've been around as humans for the past 2.6 million years. We haven't been obese for the past 2.6 million years. We've just started becoming obese in the last 100 years or so, yeah? So, up to, say, 10,000 years from now, we were living in the Paleolithic period where we used to hunt and gather, we used to use stone tools and all that kind of stuff. And our body habitus was different then, right? So from 10,000 years till today, we call it the Neolithic period, where we started growing crops, dairy, livestock. We had very limited calories, but abundant exercise, okay? And then something happened. Industrialization happened, right? So we are now living in the obesogenic period. We've added salt, we've added fat, we've added sugar. We are doing mechanized farming all over the world. We are all starting to eat the same. We grow rice, we grow wheat, we grow corn. So it's industrialized. Everything has become corporate. We're getting Pepsis, we're getting Cokes, all that kind of stuff. Processed carbohydrates. We are eating through the shelves in a supermarket. No longer are we cooking what we grow from the farm and eating it. And it all comes with side effects. Everything that we put in our mouth comes with effects. Some good, some bad. So you need to be intelligent about what you put in your mouth, okay? Limited exercise. So previously we used to walk, right? When I was growing up as a kid in India, I would cycle kilometers to go from one place to other, even when I was studying MBBS. But now, we're all going by cars, by trains, by airplanes, and hardly any exercise at all. So, it's taken us 333 generations to become obese, okay? So, what we'll do today is we'll talk about how is weight categorized, how are we progressing in our efforts to combat obesity, okay? And what's the problem? Why does Dr. Rao and his colleagues jump up and down about people who are obese? Who's to blame? How does surgery and lifestyle changes compare? Who else, apart from Dr. Rao, thinks that surgery is a good idea? Who are the right people to have surgery? And finally, we'll talk about the sleeve gastrectomy. Okay, now this is a very good slide. This is what physicians use to categorize obesity, and I think this is a better form of categorizing high-risk people, right? So for a male, if you measure your waist circumference at the umbilicus, at the biggest circumference, less than 94, you're healthy. More than 102, you're at a very high risk of developing cardiovascular symptoms very soon. Okay? For women, less than 80 centimeters, excellent. More than 88, you are at a high risk of developing cardiovascular symptoms. Now, Surgeons use a different criteria, right? There is no right or wrong answer here, but like I said, to me, the physician's way of classifying is a good way of stratifying, high risk versus low risk and developing problems. So between 18.5 and 25 is healthy weight. Between 25 and 30, you are overweight. More than 30, you're obese. More than 40, you're morbidly obese or clinically severely obese. Or if you're 35 with one or two obesity-related comorbidities, will still be classified as morbidly obese or clinically severely obese. Okay, so just to put things in perspective, for a 6 feet male to be at the higher limits of a BMI of 25, you'll be 84 kilograms. To reach a BMI, the same person, 35, he's carrying 34 kilograms more. To be a BMI 40, that person's carrying 50 kilograms more. Yeah, we have become used to seeing people who are big and look normal and accept it as being okay. All right, but the world is changing. So, how are we progressing in our efforts to combat obesity? Okay, so this is a slide. This paper was published in 2011, and this chap looked at what was happening in 1980 and then what happened in 2008. So we'll just concentrate on Australia, forget all the other countries, right? So in 1980, about 9% of our male population was obese. What's it in 2008? About 24%, right? And female population 1980, very similar, about 6 to 7% were obese. So more males were obese and less females were obese in 1980. And then in 2008, we are almost competing with the men. 24% of our female population were obese, okay? What's it now? Terrible. 69% of Australian adults, so this is 2014, 2019 NIS statistics, 69% of Australian adults are either overweight or obese. 2 out of 3, right? And look at this, 1 in 4, 25% of our children are overweight or obese. We need to lead the lives that we want our children to lead, right? So if we are eating unhealthy, our children will be eating unhealthy, and to them it's okay. Why? Because we were doing it. All right, so what's the problem? Why is everybody now jumping up and down about obese people and why we need to be helping them? Because there is no organ system in the body that is spared by the toxic effects of obesity. Yeah? So lungs, you get abnormal function, you get obstructive sleep apnea, but about 50% of people who are more than a BMI of 50 will have this obstructive sleep apnea. So the bigger you are, the chances are you'll be having this. And people who don't have partners, who live alone, will not have anybody who will witness their apneic episodes. You might be snoring, you might be struggling, but you would not know. You'll wake up next day in the morning, you'll be drowsy, you'll have headaches, you will feel absolutely restless, and you wouldn't know why. It's because of obstructive sleep apnea. Now, this is very important for you to know, because people who've got obstructive sleep apnea, moderate to severe, must be treated with a CPAP machine for at least 3 weeks before the operation. Why? If you don't, you will have what is called as a Pickwickian syndrome, where you're flitting in and out of ICU because we are not able to extubate you properly, because you're not breathing okay, and your carbon dioxide levels go up, your blood pressure goes up, you'll get more and more drowsier, the oxygen levels go down, and we have to intubate you. If you're uninsured, and if you're coming as an uninsured self-funded patient, this process of going into ICU will cost you $3,000 per day. Right? So if you've got any symptoms of sleep apnea, shouldn't be chipping on a few $100s because you'll pay more if you're staying in ICU for a few more days. Now, fatty liver. Lots and lots of people are now coming to us knowing what fatty liver is. So non-alcoholic fatty liver disease. You'll be surprised to know that the biggest cause of liver transplant in Australia, in WA at the moment, is fatty liver. Fat has the same toxic effects on liver as alcohol. So if you have a fatty liver and you're drinking alcohol, double whammy. Okay? Now, gallbladder disease. Gallbladder is, everyone comes and asks me when they're signing up for the consent, Ravi, what about gallstones? What about gallstones? Gallstones are like the garden weed. They're that insidious, right? 60% of us will have gallstones and go to the grave without the gallstones causing us problems. Okay? So these were in the days of anatomy where they were trying to do cadaveric dissection and learn about the human body. 60% of them had gallstones with no problems whatsoever, never complained of gallstone disease. Now, if you're obese, you get gallstones. If you're over 40, you get gallstones. If you're female, preponderance to gallstones. If you're fertile, preponderance to gallstones. If you get pregnant, you can get gallstones. If you lose weight rapidly, you get gallstones. If you've got Crohn's, you get gallstones. So obesity and obesity surgery have a causal relationship with gallstones. What do we do? If you're not having any issues, we leave it alone. If you have an issue, we take it out. Simple, okay? Lots of people have gynecological abnormalities, menorrhagia, infertile. Okay, previously, I think with infertility and obese people, there used to be a lot of attempts at IVF and all that kind of stuff. But now, people are being asked to lose weight, rightly. Okay? And people come to my clinic, they have the operation, they lose weight 3 to 6 months, and then suddenly they stop losing weight, and then I'm freaking out, and then after 3 more months they come back, they've put on more weight, I freak out more, and they tell me, calm down, Ravi, I'm pregnant. Okay? Which is a good thing for them, but for people who are young and are looking at pregnancy, we advise them not to get pregnant for at least 12 months, preferably 18 months after bariatric surgery, because you need to be well nourished yourself before you have another life growing inside you. Yeah? There have been a lot of accidents where people have gotten pregnant, very quickly. We do manage them, but it can be, quite an arduous process. So best is to avoid getting pregnant for at least 18 months after bariatric surgery. Osteoarthritis. The more weight you carry, mechanical joints, they're going to complain. Skin, causal association with psoriasis, eczema, gout. Now, gout is people who already have gout and have bariatric surgery can have an acute episode 2 to 3 weeks after surgery if they are not well hydrated, right? So you need to keep your hydration up. Idiopathic intracranial hypertension, where the fat in the belly is pressing on the venous return to the heart and the blood pressure in the brain goes up. Now, this is not uncommon in young women, and bariatric surgery does help them, okay? People who don't take care of this can actually become legally blind because of the pressure on the optic nerve. All right, so stroke, cataracts, heart disease. So you can get diabetes from being obese. You can get bad cholesterol from being obese. You can get hypertension being obese. This is the classic metabolic syndrome we see in people who are obese and coming to see surgery. All right, and having bariatric surgery reverses this. Bariatric surgery is now becoming like cardiac surgery. Cardiac surgery 25, 30 years ago, only a select number of patients were being treated and offered cardiac surgery with experience, with technology, with the advance of medications and all kind of stuff. Now, if you are 75, if you're 80, if you're fit for surgery, and if the quality of life is going to get better, you will be offered cardiac surgery. So bariatric surgery is still the same. If you are fit for surgery, we will give you the surgery because your quality of life is definitely going to be improved, all right? You got pancreatitis, cancer, 16% incidence of increase of these cancers in obese women, okay, and men, all right? Phlebitis, venous inflammation. So there are a lot of people who are obese, come with varicose veins, yeah? So you get all of this. So that's why we are concerned. The burden of these complications on our health system is very high. We've been trying to educate not only patients, but also presenting to the government about why bariatric surgery should be given, offered to public patients in higher numbers, because when we operate on them, all those complications that we are talking about go away and saves a lot of tax dollars, okay? But the government has still not increased the numbers. So who is to blame? Now, there is a stereotype that in the Western world that people become obese because they're lazy, they're unmotivated, they eat more, they don't exercise, blah, blah, blah. So what is the real reason? Are patients really to blame? Now, this slide's taken me 8 to 10 years to understand, so I won't be able to make you understand in few minutes. It's very busy. What it essentially means that the regulation of energy and metabolism is a condition where, you know, there should be homeostasis between the brain at the center, which acts like maybe your CPU, central processing unit, like a computer, along with the peripheral organs. All the organs have a role to play, right? And the talk between these two is neuroendocrinal, hormonal impulses being sent to and fro nerves, okay? So it's not as simple as what you put in your mouth, what you expend as energy, right? It's not. There is a lot of things going in the background. So in the brain, it's the hypothalamic region that regulates how much food you eat, how it gets metabolized, and how the energy expenditure is affecting everything, right? So say, for example, the stomach, the hormone ghrelin. Now, we all know hormone ghrelin because of the sleeve gastrectomy. It's become very, very popular. So it's the hunger hormone, right? Now, at the periphery, you've got the intestine that does secrete the peptide GLP-1, and the pancreas insulin, incretin in response to food. Now, these hormones are the reason why the bypass works much more efficiently than the sleeve gastrectomies, right? So these have a role to play when they feed back through their secretion to the brain when the food is passing through those areas, right? Liver. The skeletal muscle also has a role in production of insulin and glucose, and they've got receptors there that can sense how much insulin is being secreted. Newly accepted functions, we know now that leptin, adiponectin, IL-6 is very important in the hormonal regulation of energy balance, all right? So it's very complicated. It's not as easy as just eating and then energy expenditure. So Proito was the first guy to study about weight regulation through the hormones and influences on the desire to heal. So he described that ghrelin will cause hunger. He described that inhibition, satiety, through the gut with these hormones, through the fats. The biggest hormonal gland, if you may, in the body is the adipose tissue, the fat between the skin and the bones, right? And it secretes leptin in response to various stimuli, and through the pancreas where insulin is produced, and PP and amylin, all right? And all these impulses through the brainstem act on the paraventricular nucleus or arcuate nucleus, and also there is cerebral cortex where you have conscious will of how much you want to eat or not. Okay, so this guy started it all. Zen. He described that a person just cannot become obese by simply overeating and lack of exercise, right? So there has to be a predisposition. There has to be an internal wiring, and that needs to be combined with an environmental trigger. And this was taken forward by Lee Kaplan, who has about 20 years of research and published the MARS strategy in 2015. And because of his study, now we know, why people become obese, why the surgery works, how the surgery works, how different surgery works, and why people fail the operation, right? So I'm going to tell you something very simplistically, what Lee Kaplan took 20 years to find out, all right? So you don't become obese by simply overeating and lack of physical exercise. You must have a genetic predisposition, a gene, and that gene needs to be predisposed to an environmental trigger, right? If you don't have the gene, you may have maladaptive eating habits, you may guzzle alcohol, you will never put on the kilos. Yes, you will have all the other problems that come along with it. You can have clogged arteries, heart attacks, type 2 diabetes, hypertension, bad cholesterol, everything else, but you won't put on the kilos. You must have a genetic predisposition to becoming obese. And then when this gene is triggered by an environmental factor, that could be anything. Grief eating, comfort eating, anxiety, depression, alcohol, cigarette smoking, hungry jacks, McDonald's, oral contraceptive pills, pregnancy, childbirth, medications we take for psychiatric illnesses. 95% of those increase weight, right? Steroids increase weight. Some medication we take for diabetes increase weight. Some medications we take for bad cholesterol, like statins, they increase your blood sugar, increase hunger, increase weight. So the same medications we use to treat the diseases caused by obesity further cause obesity, right? So we are living in an environment which is full of obesogenic triggers. When this trigger hits the gene, that's when you start becoming obese. So how does this work? And this is what is described by Lee Kaplan. All of us have a metabolic set point in the hypothalamic area of our brain that basically doesn't allow our weights to go above or below a particular number, right? So when the trigger hits the gene, this metabolic set point goes faulty. So now you're on an ever-enlarging pathway and your set point is dragged along with it, right? So today, say if one is 120 kilograms, the brain thinks 120 kilograms is normal because that's where the set point is. But that person knows it's not normal because he or she has seen better days. So this person goes dieting, exercising, boot camping, medications, yada, 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 loses 5, 10, 15, 20 kilograms in say 6 to 9 months, huffing and puffing, and then gets frustrated because whatever that person is doing to lose weight is unsustainable for the rest of his or her life. And then when that patient stops, the brain reckons, hang on, the metabolic set point is at 120, but the person is at 100 kilograms. No can do, because the set point dictates where your weight is going to be. Brings you straight back up to 120 and maybe adds a couple of kilograms more, just as buffer, just in case the naughty you decides to do this again. Right? So this is the yo-yo pathophysiology weight loss of obesity. All right? So how does surgery work? Okay? Again, very simplistically speaking, what Lee Kaplan took so many decades to realize, I'm going to tell you in 2 minutes. Okay? So surgery works on the principle that we cut your stomach to such an extent or change the plumbing of your guts to such an extent that your brain panics into thinking, evil bloody Dr. Rao, he's done something terrible to your stomach. Yeah? You guys have beautiful large stomachs. He's now reduced it to a piddle. Right? So the brain panics that you will not be able to eat and drink well enough to sustain life. So it is this panic response or flight response as we call in medicine, that makes that brain do hormonal changes. Different surgeries elicit different hormonal changes, but the net benefit of any one of this: burn fat, convert to fuel. Burn fat, convert to fuel. That's why you're losing weight. You are not losing weight because you're eating less. You understand? Otherwise the bands would have worked, otherwise dieting and exercise would have worked. Okay? Now, after a period of time, the brain figures out Dr. Rao is more evil than it perceived to be, because it's been tricked that you guys are eating small amounts but making enough energy to sustain life by yourself. So why does the brain have to do the same thing that you are doing? When it recognizes that fact, it slows down those hormonal changes and comes to a complete stop. When those hormonal changes stop, your weight loss stops. Otherwise, what prevents you from losing weight all your life and dying? If eating less is supposed to make you lose weight, I want you to eat less for the rest of your life. You should die. No. The brain is doing what it's doing with hormonal changes. When that stops, your weight loss process is over. Okay? At the time when that happens, it recognizes that in its initial circuit diagram, it had a set point. You understand? It knows it needs to reset. It doesn't know what the set point was, whether it was novel, broken, or whatever, because it's induced to all these changes. It knows it needs to reset, so it hits the reset button at the weight you are at that point of time. Right? So what does surgery do? Gives you an exaggerated weight loss, more than dieting and exercise, and a reset button that should help you be at that weight for a longer period of time. No other modality, dieting, exercise, medications, yada yada yada, addresses this set point problem. That's why you're yo-yo. Okay? So surgery gives you one-off exaggerated weight loss and a reset button. However, it does not address your gene. Right? So if you don't change your lifestyle and behavioral attitudes towards eating, drinking, alcohol, cigarette smoking, yada yada yada, you could trigger the gene and put the weight back on. So bariatric surgery is just a tool. It is not a cure, it's not a magic bullet. It doesn't last for the rest of your life. Bariatric surgery with lifelong maintained lifestyle changes will help you give proven long-term effective weight loss. Right? And there is no surgery that does not fail. There is a misconception that, okay, sleeve gastrectomy, if you have that, it's going to fail after 5 years. People who talk do not understand the concept. There is no surgery that will withstand the onslaught of this or this, not even a brain transplant. Yeah? So you guys, if you have bariatric surgery, and if you want and are ready to adapt your lifestyle to your new plumbing, have the operation. If you want to eat and drink like you do now, have the surgery as a shortcut to weight loss and go back to how you were eating and drinking before, run away from here right now, because you'll get back to where you are now. Yeah? Okay, silence in the room. All right, okay, look at this, my favorite slide, yeah? An average adult, right, when I say average size adult, requires around 8,000 kilojoules in a day for energy. Look at this beautiful, happy meal, yeah? Cheapest that you can ever get, quick, on the run, on the go, everybody loves it. 6,510 kilojoules. And how much do we put in our mouths after having this? Yeah? We've got to change the way we eat and drink, okay? So how does surgery and lifestyle compare? Okay, this was 2013, they've come back yet at 2018, so if you diet, you'll lose 3 to 5 kilograms at 12 months. At the end of 5 years, you're back to where you were before. You add exercise to it, you'll lose 5 to 10 kilograms at 12 months. You're back to where you were before. In fact, you may have put on 3 more kilograms. Exercise, the squat. At 5 years, you put on 5. right? So if exercise was going to make us lose weight, right? All the guys who are pumping iron in the gym 3 days, 5 days, they should be losing weight, right? Don't, because the brain is controlling everything, okay? So you add medications to it. It doubles. Now this is the number that's changed in 2018 because of the newer medication stuff we've got, like Saxenda, liraglutide and all that kind of stuff. You lose about 10 to 15 kilograms at 12 months, right? And to keep that weight loss off, you've got to be on that medication for the rest of your life. It's not covered by Medicare. A monthly prescription is $400. You take it for a year, you might as well have the sleeve gastrectomy. Yeah? So medications don't work because they don't address the set point issue. Okay? Now, bariatric surgery with maintained lifestyle changes. Not just bariatric surgery by itself. Gastric band is rubbish. I hate it with a vengeance. I've never put a band in my life. I've only removed them, so we won't talk about it. Almost 3 out of 3 bands are coming out in WA. Okay? Sleeve, you lose 20% total body weight at 12 months, and at 10 years, if you maintain your lifestyle changes, you're still off a lot. You will put on 5%. Now remember, when you have surgery, you will lose with the sleeve all your weight, whatever you needed to lose, and I'll tell you how much you are expected to lose at the end of 12 months. When it stops, the hormonal changes stop, you put on a couple, and at the end of 2 years, you put on a few. So that's a rebound phenomenon, right? Because there is jejunal break, ileal break. These are methods of digestion which are modified by these operations, and when they come back to normal, you have that rebound phenomenon. That's fine. That's why if you think, oh, I'm losing a little bit more weight and I don't want to, I'm very comfortable at this weight, just let yourself lose all what the body is losing, because at the end of 1-2 years you will have a rebound phenomenon. But even accommodating that, if you do the right thing, you will still keep a lot of weight off at the end of 10 years. The Room 1 gastric bypass is the gold standard, because that's the most amount of surgeries that have been done in the world, especially in America, where we have long-term data. 33% of total body weight loss at 12 months, and look at that, at 10 years you are still at 30%, right? And we've now got the SIPs. I'm the first guy to have started the SIPs in WA, if not in Australia, and I've published my 2 years results. I'm at the moment looking at my 4-year results to publish them. It is almost similar, if not better, right? And the quality of life of the patients is much better than the room, okay? All right, so what do organizations say? Who apart from Dr. Rao thinks that it's good? You've got the NHMRC that says surgery is the most effective in obese patients, that it reduces the comorbidities, particularly diabetes, improves your quality of life, and that obesity is one of the most cost-effective treatments available, right? We're trying to impress upon this to the government. Diabetes Australia says that people with type 2 diabetes with a BMI of 35, a lifestyle intervention, and other treatments have not worked. Bariatric surgery is good, and the success varies. Now, there are 2 factors for success of bariatric surgery, right? It's the type of surgery offered and patient, right? You may do whatever surgery you want, but if the patient's doing this, drinking alcohol, you ask 10 people who failed bariatric surgery, were they drinking alcohol after the surgery? Immediately after the surgery? 1 year after the surgery? 10 out of 10 will tell you yes. Most common factor in failing the operation, most common trigger for triggering the gene, okay? So, this is a consensus statement, and this came out in 2011, right? That preventative approaches to weight gain, all the conservative approaches to weight gain, on their own are not effective in treating people who are already obese, right? So you can, if people have become obese and you're putting them through dieting, you're putting them through exercises, you're putting them through medication, it's like flogging a dead horse, right? It does not work. That will work if you operate on them, give them the metabolic change that is required, and then have all those changes, okay? And any algorithm for obese people with type 2 diabetes must have obesity surgery, must include obesity surgery. All right, so now we'll talk about the sleeve gastrectomy, okay? Now, what is the sleeve? Now, 65 to 75% of your stomach is removed, okay? Now, the stomach that's been removed is actually the portion of the stomach that is thin and balloon-like, that dilates and accommodates to overeating and helps in the churning mechanism that will help digestion of the food to an extent where it reaches that consistency and this pylorus opens up and the food goes down, right? So we've removed that portion of the stomach. So what you're left is a banana-shaped stomach, literally the size of a banana. It is made of thick muscle. There is no longer that thin balloon type muscle which will accommodate your overeating. If you overeat here, the pylorus is not going to open up. If it hasn't reached that consistency, the food's going to come up. So, exactly. So the most common cause, 95% of the reason of vomiting, reflux, heartburn, nausea after this operation is overeating. You've got to learn to adapt to your new stomach and stop before you're full. It's difficult, right? Because you've got corporate memory of how you're eating and drinking now. But after this operation, you've got to become like a baby, where when you put food in your mouth, the baby is full, it turns away. That's what you got to do, and you got to learn it. Different foods of different consistency after this operation will fill you differently. So it's a learning game, right? So that's why we give you 4 to 6 weeks of, different kinds of nourishing liquids or soft diets or blended and pureed diets, so that you learn when to stop. Okay? And the fact that you shouldn't eat and drink before, because the space is so small, we want you to fill it with nourishment. So if you're drinking and eating at the same time, it's not going to go down, it's either going to go up, or if you push it down because of whatever you're eating, not only will it go up, it will push it down, undigested food. Secondly, you will lose satiety, right? So you should learn to readapt to your new stomach, okay? So with the sleeve in literature, when the operation is done by any Tom, Dick and Harry and his dog, is about 50 to 70% excess body weight, right? So if your excess body weight is, say, 50 kilograms, you will definitely lose 25 to 35 kilograms more. Yeah? In my subset, when patients follow the rules, we reach around 80% and beyond. There are people that have lost it all. So always remember, when you have any numbers, there are some people who will be at the left of the curve, some people who will be at the right of the curve, but it's the middle bell curve that you look for. So that's 50 to 70% in literature, okay? Ghrelin is removed, so you don't feel hungry. So less hunger, less craving. People who've got problems with I like this, I like that, or binge eating, can get it under control. But it lasts very less time. You get the hunger hormone back within about 6 to 9 months. Because that is the natural mechanism of the body. It's a defense mechanism. You need to be hungry to eat, right? So that comes back. So the 6 to 9 months has given you enough time to condition your brain to understand, is all I need is this much. Because you're still alive when you're eating that much, right? And you've got to understand you're coming from behind. All you need is that much. If you eat more, you are at a risk of putting the weight back on. Right? So it is how much the sleeve allows you. Instead of eating 3 small meals, eat 5 small meals. There will have to be protein supplementation in terms of powder and liquids. Right? If you try to get all your protein requirements with that small sleeve, okay, you can eat normal food, but with the normal foods, things like red meat. Now, eating red meat for obese people, in fact for all of us, is not recommended, right? Even the Cancer Council has now come out of Australia that red meat is carcinogenic and you have alcohol along with it, it potentiates the effect. When obesity is concerned, even a small amount of red meat will give you a humongous amount of energy that you don't need, right? And it's going to be very difficult for you to digest it. Even a small amount you eat there, it's going to get stuck in there, digestion takes longer, you will feel horrible. And if you eat more, and if it stays up there in the chest, it mimics a heart attack. And you're going to ED with chest pain, you're being investigated for a heart attack, everything comes normal, then they call the bariatric surgeon saying, oh, she's in a lot of trouble, and we just say, ask them what she ate, or he ate. And then when you tell them, we'll say, look, no matter what pain relief you give, it's going to hurt them. Once the food gets digested and passes, they'll feel normal again, right? So stay away from red meat as much as you can. Chicken is average, doesn't do you good, doesn't do you bad, but again, it will cause difficulty in digestion in the initial period. So have very small amounts, puree them very well, or chew them very well, okay? Ease of secondary procedures is not something that we need to have as an advantage, but in those people who do fail this operation, there is a revision. We now know that obesity is a chronic medical illness. So in academic circles, when a very young person comes to us with super obesity, we offer this position because we need to have something else to stage if they are, say, 20, 24, and they come back in another 10, 20 years, regaining their weight, they are still very young at 40, 44. If you do the bypass, we can't offer them anything, all right? So it's staging the illnesses like we do with the chalacea. There is no malabsorption or non-absorption. Yes, you will have issues with vitamin B12, iron, calcium, and all that kind of stuff. So unfortunately in Australia, there is no vitamin that addresses the specific requirements of a specific operation. They are just generic. Our practice prescribes and compounds the specific requirements, and we will give you information about that, and it is much more cheaper than any commercial preparation, right? It's $30 a month for calcium, for your iron, and all the other multivitamins you need. Moderate efficacy, right? Because every surgery has its potency in terms of weight loss, in terms of diabetic resolution and all that kind of stuff. And in that respect, this is moderate. Okay? Now, what are the issues? Any operation comes with issues, right? So the best issue is the weight loss. We want that. But then you've got to accept other stuff as well, like eating less for the rest of your life. Like if you overeat, you're going to vomit, you're going to have reflux, right? So it's irreversible. I can't bring back that stomach. Gone. So when people say, oh, it's easy because we don't change the plumbing, you're still removing the stomach. It is irreversible. Leak rates in primary cases, in people who don't smoke, who don't have medical comorbidities, who are not on steroids, who are not on immunosuppressant medications and all that kind of stuff, the leak rate should be less than 1%. Now, two things that can happen in as a complication of this surgery you need to understand is the leak and a bleed. Why is leak, so devastating with a sleeve gastrectomy? A leak may be a small pinhole in the staple line, usually at that area, right? In a big normal stomach, if you put a hole and suture, right, it heals within 4 to 5 days. A small pinhole in the sleeve takes 6 to 12 weeks to heal, no matter what we do. When we have this situation, whatever operation or operations we do to sort that is only aimed at damage control, minimizing the contamination and sepsis because of the acid coming out, and feeding you by artificial methods to let the hole heal. And whatever, you've got a lot of options, but whatever options we have, it takes 6 to 12 weeks to heal. So less than 1%, very rare, which is great, but to that one person who has it,
not so great.
Exactly, right? But part and parcel. Now, for uninsured patients, this is an issue. If you have this complication, I'm very happy to take care of you, but if you cannot afford the finances of me taking care of you in the private, you have to go to the public system, right? Unfortunately, that scenario is rare, right? But if you do have any issues, you will need to go to the public system. 1% bleed. So the stomach here is has omentum very close to the spleen, all arteries, liver. The risk of you having a bleed, because of which I have to take you back to theatre, is less than 1%, right? The risk of you having a bleed, it's the other way around. The risk of you having a bleed, because of which I have to transfuse blood in you, is less than 1%. To take you back to theatre to stop that is even rare, right? 20 to 30% failure rate at 5 years. We've got to give you this number, but this number is not because the operation didn't work. If it gives you weight loss and stops, the operation has worked. If you fall within the 50 to 70%, the operation has worked. If you don't watch what you put in your mouth, if you don't watch about the alcohol content, the sugary drinks, the carbonated sodas, all that kind of stuff, you will be a statistic in that number, all right? Reflux. Now, if you eat more, like I said, it's gonna come up. So that is the most common cause of reflux with this operation. This is a high pressure system, even in normal people. When I say normal people, people who haven't had surgery. If the pressure here, this allows the food to come down, but not go up because of the high pressure. If the pressure there is less, then you get reflux. This is a high pressure system. When the pressure there is more than the pressure there, you will get reflux. Now, most people equilibrate in about 3 to 6 months' time, right? So with reflux and sleeve surgery, usually we give you medications for the first 3 months, and then afterwards, most people don't have it, you stop the medication. Some people will still continue to have it, then we'll give you medication on a lower dosage. If you continue to have it, we treat you like anybody else. If people haven't had the operation, your reflux is well controlled with medication, we'll let you be, right? But in those cases, you must have an endoscopy once every 3 years to make sure that the lining inside your esophagus is normal.
I do.
Yeah?
Because I
Yeah.
suffer.
Yeah. So, very rarely does somebody need a surgical operation to cure it. And the most common cause there is when this has migrated up into your chest, right? With weight loss, sometimes you can get weakening, the fat is lost, then it can go up, right? That's the paroesophageal hernia. That's the most common cause where we'll need to operate and get rid of it, okay? Now, any questions with regards to this at all? Oh, good. All right, so, for those of you who are still undecided, I'm sure all of you have come to me because you've decided, but there are a lot of people who don't know what's the right answer. If you have bariatric surgery, you lose up to 50 kilograms. Now this is, again, it's a very generic figure, and you have decrease in your comorbidities by 80%, right? If you've got more medical therapy, people are flogging you, dieting, exercise, yada, 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 you will just keep putting on more weight. But diabetes is going to get worse, increased mortality, and increased cost to you and to the government in countries where we've got socialized medicine. Okay, questions? Geez, I'm good, hey? Questions?
I've just got a few questions.
Yeah.
I've got a few other underlying health issues.
Yeah.
So I'm hoping that I'll make some of them a lot better.
I hope too. So, with individual stuff, we'll discuss one to one. Yeah? Oh, yeah. Questions? Questions, ma'am? No? I think she understood it most because she was nodding her head. And every pertinent stuff I was saying, she was nodding her head. So I'm very impressed with her. You got any questions at all? All right. Okay. So thanks very much for your time and patience. I will see you guys shortly. We'll do a one-to-one very quickly and we'll take it from there. Yeah? Thanks. Cheers.
Thank you. Thanks.